So next we have another presentation, role of fluidics in post vitrectomized eyes by Dr. Manas Nath. He is another wonderful surgeon. I am sure everyone will love seeing his videos. So over to you, Dr. Manas. So this is the last talk of this IC. And since we are running short of time, maybe we'll just take up one or two questions. And if anyone has any queries, all our instructors, co-instructors are available for discussion anytime, maybe in the IT area.
Maybe little less if possible. 40 is the standard. Nowadays you are using with 40 only. So maybe
that's what I said, that it can become lower also.
Yeah, 30.
Maybe even lower.
Even lower, okay. We'll try it.
Okay, Dr. Manas.
Yeah, thank you, Dr. Jeshi, for giving me this opportunity. So I'll be talking about role of fluidics in post-vitrectomized eyes. Partial vitrectomy is now a frequently performed retina surgeries, and for the last decade, the visual outcomes are quite promising because of advancements in the machine technology and the surgical technique as well. But there is a risk of cataract progression in up to 80% of cases within 2 years, and there is definite role of anti-segment surgeons to play because this extra burden will definitely fall on them. So phaco after PVV is always challenging, not only because the cataracts are harder and denser, but also it is associated with some syndromes like lens iris diaphragm retropulsion syndrome, which has already been discussed by our previous speaker. So here, as the vitreous support is not there, as soon as you introduce your phaco probe inside and press the irrigation foot pedal, there will be certain deepening of the anterior chamber, as you can see here, and one is to bend the phaco tip too acutely to reach the surface of the nucleus. So in that there will be stretching of the iris leading to pseudopupillary dilatation, stretching of zonules, and posterior displacement of the iris lens diaphragm, and it can lead to severe ocular pain if it is done under topical anesthesia. And as per Dr. Sioni, he published his technique in 2004 in JCRS. Here you just have to lift your iris with any instrument so that the balance will be there between the anterior and posterior chamber, and the chamber will become relatively normal. But in doing that, the pupil can become relatively small and the surgery can become a little bit complicated. There can be chances of posterior synechia, zonular damage, and even posterior capsular tear. Here you can see that there is a linear capsular opacification suggesting a lens touch during your retina surgery. Capsular exit can be difficult because as the vitreous support is not there, one is to put a little bit of extra force to initiate the capsular exit tear, and sometimes the entire capsule will be too much, there will be too much of fibrosis. And infusion deviation syndrome is not very uncommon. And even your silicon oil in the anterior chamber is always associated with poor visual outcome because it hampers with your preoperative and intraoperative procedures, and itself it can damage the corneal endothelium. And if you see a cataract, total cataract like this immediately after your retina surgery within 3 or 4 weeks, one should suspect a posterior capsular dehiscence. Proper history taking is very important because one has to be clear that this present visual loss is because of cataract and not because of the pre-existing retinal disease. Biometry is also very challenging. I'm not going to talk about biometry here because it is out of the scope of this IC. Thorough slit lamp evaluation is important. Here you can see that there is localized posterior capsular opacification, and on table the surgeon noticed a linear capsular tear. Even a B-scan, AIOC or EVM can be used to look at the integrity of the posterior capsule. Sometimes ILMSA 700 can also help. Here you can see that the ILMSA 700 image showing a dehiscence or your loss of integrity of the posterior lens capsule. As mentioned by our previous speaker, the incision should be watertight always, not only side port but our main incision as well. It should not be uniplanar, as you can see here. And making a scleral tunnel will be difficult because of conjunctival scarring from the previous retinal surgery, and clear corneal incisions are preferred. And try to avoid making a very long clear corneal tunnel, as you can see here, because in this case also you have to bend the instrument down too much, too acutely, and where already the chamber is deep because of the previous vitrectomy surgery, it will lead to folds in the cornea, and visualization during the surgery will be compromised. And the altering the phecoparameters is also very important, as already mentioned by our previous speakers. And to have a reduced AC depth, chamber deepening, one should lower the bottle height, as we know that the balance between inflow and outflow should be there. So accordingly, your flow rate vacuum should be reduced up to a level that you don't encounter surge. And this lowering of the parameters will definitely slow down your surgical speed, but as we know, slow and steady wins the race. Fluid infusion deviation also not very uncommon here. In this case, what happens, as the zonules are weakened because of the previous retinal surgery, the fluid can pass through the zonules and it accumulate in the vitreous cavity and can lead to your positive vitreous pressure, leading to shallow anterior chamber. So it has been postulated that if you keep your phaco tip posterior to the iris plane, the chances are higher of getting deviated towards the vitreous cavity. So in this case, lower the bottle height in case of raising it, and try to keep the phaco tip anterior to the iris plane, and try to avoid doing in-the-vac phacoemulsification if one is experiencing abnormal fluctuations in the anterior chamber. Doing a 20 gauge or a 23 gauge vitrectomy is of no use because there is hardly any vitreous to be removed, nor there is any role of mannitol, as there is no vitreous. So obviously one can put a valve trocar cannula. So here, with the help of this, the fluid can be removed, and once the eye becomes firm, the cap can be placed and the surgery can be continued. Let's see some of the surgical scenarios here. This is a case of a post-PPP surgery done for ERM many years back, and now the patient presented with your vitreous hemorrhage from diabetic retinopathy. And probably because of this light, the image is not very clear. And the glow was not there because of the vitreous hemorrhage behind. Stained the capsule with tryptophan blue, trying to make a relatively larger capsulorhexis for better visualization for the retina surgeon. Hydro dissection will be really difficult here because one will not be able to appreciate the fluid glow. When I'm also not able to appreciate the fluid glow, your fluid wave, it has to be very gentle. So during phacoemulsion, what I do in this kind of cases, I take a spatula in one hand and introduce my phacoprobe in 0 mode, and before initiating the foot pedal 1, I just lift the iris so as to prevent the reverse pupillary block to happen, and which will prevent the sudden deepening of the anterior chamber, and then one can continue with the phaco surgery. The real challenge comes when is doing the bimanual irrigation aspiration. So here, as soon as you introduce your irrigation cannula, you see that there will be sudden deepening of the anterior chamber. So in this case, I just lifted the iris with my another instrument. The chamber became normal, and one can also inject viscoelastics, which will maintain the anterior chamber. And next time when you introduce your irrigation port, there won't be any reverse pupillary block, and one can continue with the surgery. Then lens is placed in the bag, and the surgery, then the patient is sent for the retinal surgeon for doing the vitrectomy. So another case is a post-vitrectomized eye. You can see altered glow here, and this is because of the residual gas bubble which is still there. This is actually a C3 effect, and it made the surgery really challenging because we know that the gas floats upwards, and in supine position it is just behind the posterior surface of the lens. It is actually basically pushing the lens upwards and making the chamber shallow and making the surgery very difficult. So I called the retinal surgeon for help. He came, and with 30 gauge needle in one hand, he's trying to aspirate it, and with the other hand, he's aspirating, he's injecting fluid in the vitreous cavity so as to prevent any hypotony, profound hypotony. And now you can see that the residual bubble is being aspirated, whatever minimum amount possible. Simultaneously, fluid is being injected from the other side. Checking the firmness of the globe, eye is found to be firm, and then I continue with the surgery with placing iris hooks. But still the bubble was there, which is hampering my view. Definitely I proceeded carefully with phacoemulsification, lower parameters, But during cardiac aspiration, you can see that the PC is bulging forward. There is too much of PC bulging from behind because the air bubble is there just behind, pushing the PC forward. And even with lower parameters, I was really scared to do. Anytime anything can happen, so I called the retina surgeon for help again. So he came and aspirated. So I also feel that there can be a component of fluid misdirection in this case as well. So here the retina surgeon came and because in this case, without removing the air bubble, I will not be able to inflate the bag to please the lens. So there's a retina surgeon aspirating the air bubble. Sorry for the decentered view. And now you can see that the bubble can be displaced, and I could inflate the bag with viscoelastic, and then I could please the lens in the capsular bed and can finish the lens. The case. So to conclude, to deal with these kind of cases, one should have a better understanding about the phaco machine and its parameters. And I feel that this kind of cases should be dealt by the experienced surgeon available on that day, because successful cataract surgery in these patients is very important to restore their vision and to give the retina surgeon to have a clear view to monitor the posterior segment in future. Thank you. Thank you for your patient listening.
That was wonderful, Dr. Manas. I would like to ask you one thing. How will you manage a case of lens touch during PPV, first planar vitrectomy?
So you have to have, thorough slit lamp evaluation. Here we have to do, as I have shown in the picture, you can have a linear opacification kind of thing. And sometimes if you know the retina colleague, you can ask directly whether you will ended up in some complication or you ended up in some touch with the instrument, with the lens, or with the instruments. And you should evaluate through that. Not only slit lamp evaluation, there are other newer gadgets like AIOC can be used, or even ILMS 700 can be used if there is no total cataract. And you should proceed with the case as we will proceed in a case of posterior polar cataract. No hydrodissection, only delineation, avoid any chamber collapse. Whenever you're taking out the instrument, put viscoelastics, like that.
Okay.
There can be a PC dehiscence, there may not be, but you have to deal with any lens touch like you are dealing with a posterior polar cataract.
Okay. So any case that you have where you are in a doubt that maybe there may be a PC dehiscence, so we'll manage as we manage a PPC,
definitely,
as you said.
definitely.
Okay. So any questions from the audience for any of our instructors, co-instructors?
Will you consider hydrating the site?
Not required. Because now in high-end machines, in a saturated light, we don't require it. The active fluidic system is already managed.
So the high-end machine is not there.
Not there. And you have to, if you are using a lower gravity based, then increase your bottle height, decrease your AFR. More fluid is.
Will you consider another site?
But that is I already told. If it is too much leaking, like my video, then you can just stop it, make another parasitic of the side for and use that one.
And using viscoelastic is more important last piece.
Yeah, that will.
Yes, and it's actually a good practice. No, when you are removing the last piece, it's better you go for viscoelastics. Even if there is no PCR, just try to make your left hand more maneuverable so that you can use it, and then that can be a helpful practice when you actually have a PCR. Because sometimes injecting with your left hand, no, it becomes very difficult when you actually have a PCR. And also, I would like to know that suppose not the side port, we have a leak through the main wound. So a gross leak, and we don't have a high-end machine. So how do we go about with those cases?
If we have a main port incision,
Leak, yes.
then the machine doesn't work.
Yes, yes, yes.
Give us the difficulty. If we are, then the sleep becomes important. If we are using a 2.2 mm or 2.8 mm. So in a 2.2 sleeve, we cannot do it in a 2.8 mm incision. So then in case we have to give us this
Suture, yeah, we have to suture. Yeah. Any other questions?
We like to hear some tips about the anterior vitrectomy. While doing the anterior vitrectomy, the chamber must be closed. Bimanual technique is more important. And the direction of the irrigation port should be away from the rent. This is also important. And the direction of the vitrectomy port, it should be headed up so that you can see what you are cutting. These are the things, the important things, I think, to be added.
As I have just showed in the animation that you could see, the irrigation port is always above your vitrectomy cutter. Okay, it's not nearby. If you go near, it will be more or less like the coaxial. And why we are saying that no to the coaxial? Because you are hydrating the vitreous. So always the irrigation is above, and you have the vitrectomy, the cutter at this position where you have the rent, the PCR. Okay, and the movement of the cutter is not allowed until and unless you are in position 2. Only when you are cutting, then you can move your hand. Otherwise you have to, yeah.
Not go more towards the wound ruptures, right? But then pull the vitreous more. So because the cutter should not be very near the PCR part. Put the more.
Yes.
Post misdirection syndrome and
Shallow anterior chamber. What's your strategies to manage such a case? You have got a shallow anterior chamber. You cannot just wait, giving mannitol and waiting for another half an hour and continue going.
So like if it is a non-vitrectomized eye, then probably, I mean, I've faced this kind of cases many times. You cannot proceed. I mean, whatever you do, definitely you cannot put viscoelastic. Even if you put viscoelastic, iris will come. You have to wait, give it time. If you have another case, do that case. In between, you give mannitol, let the eye settle down. And then probably after 10-15 minutes, automatically when the vitreous has shrunk down, you can continue the surgery with all the lower parameters. The vitreous tap, sometimes some people suggest that one can go and remove some of the vitreous through the after doing vitreous tap. That can be done.
One thing I want to add here, like in some type of cataract, like intumescent cataract, where there is a high intralentricular pressure, in that type of cataract also we get a shallow anterior chamber. So in that type of cases, what we can do, we can just pre-operatively just do a vitreous tap, and this will really help to reduce the shallowness of the anterior chamber.
Yeah, but some retinal surgeons don't advise for vitreous tap in all cases. I don't know. I mean, the retinal surgeon can.
But for doing vitreous tap, it should be doubly so that it's a fluid misdirection. If it is suprachoroidal hemorrhage.
Yeah.
Yes. And another good point that Dr. Manas has showed in his video actually is that even if you don't have a reverse pupillary block, what he did, lifting up with the second instrument, that can be a very important point, because that will help us to prevent what was shown in the next video, the reverse pupillary block. You tend to prevent it.
Because I know that it is going to happen, so why let it happen?
Happen.